Welcome back to the Deep Dive. I am your host, and we have a pretty massive stack of research on the desk today.
We really do. And I'm the resident expert for today's clinical breakdown. I have to say, this one feels a little different from our usual topic.
Yeah, it does. Usually we're talking about, broad trends or big historical events, but today we are zooming way, way in.
Going totally microscopic.
Right, down to a moment that happens in hospitals literally every single day. A moment that, it truly defines the line between life and death.
Is the moment every single surgeon fears. You've done the work, the operation is totally over, the family is relieved, and then...
And then the silence breaks.
Yeah.
We're talking about small bowel anastomotic leaks, and I know that sounds incredibly technical right off the bat.
It's a mouthful for sure.
It is. But if you stick with us, you're going to see that this is actually a story about decision-making. It's about reading really subtle signals.
And about the high-stakes game of, well, it's essentially, catch me if you can, that doctors play with human physiology.
The ultimate game of high-stakes poker.
Exactly. And the currency in this game is time.
So to get you, the listener, into the right headspace for this, I don't want to start with textbook definitions. I want to start with a scenario.
Best way to do it, put them right in the room.
Right. Let's drop you right on to the hospital ward. Picture this. It's, let's say 2 p.m. on a Tuesday. You are standing at the foot of a hospital bed.
The lighting is that harsh, kind of buzzing fluorescent hum.
Oh, yeah. You know the exact vibe. You hear the monitors beeping out in the hallway.
Nurses walking briskly past the door.
And in the bed, right in front of you, is a 48-year-old male. We'll call him David.
Okay.
Now, David isn't elderly. He's not frail. He's just a regular guy. A dad, probably has a job he's anxious to get back to. But 4 days ago, David had a massive emergency.
He had a strangulated ileal obstruction.
Which, let's just pause right there. That is a life-threatening event entirely on its own, isn't it?
Absolutely. What happens there is a loop of his small intestine literally got twisted. The blood supply was entirely cut off.
Like a kink in a garden hose.
Exactly like that. And because the blood supply is cut off, that tissue starts to die. Fast.
So the surgeons rushed him into the operating theater. They cut out the dead piece of intestine.
Which is what we call the resection.
Right, the resection. And then they sewed the two healthy ends back together.
The anastomosis.
Reconnecting the pipes.
A very standard procedure, technically demanding, sure, but it's something general surgeons do all the time.
So the surgery was a success, and now we are on post-operative day 4, or POD4, as the charts say.
Right.
And you are looking at David, and here's the thing that makes this so tricky. He looks kind of okay.
Well, define okay in this context.
Well, he's awake. He's sitting up a bit, scrolling on his phone. He tells you his belly hurts a bit, but,
Yeah.
He just had his abdomen cut open 4 days ago.
You'd expect some pain. It would be weird if he didn't have pain.
Exactly. He does have a low-grade fever, about 37.8 Celsius.
A blip. Nothing
Yeah.
crazy.
Right. His belly is a little bloated, a little distended, and he has a tube going down his nose, an NG tube.
An nasogastric tube. Yeah.
And it's pulling up a bit more fluid than it was yesterday.
Okay, so looking at all of that, so far, you could easily argue this is just a slow, bumpy recovery.
Right. He has a surgical drain sticking out of his side, too. You look at the plastic bag hanging there, and it's just got a little bit of clear, maybe yellowish fluid in it.
Serous fluid.
Yeah, serous fluid. There's no blood. There's no green bile. It looks totally innocent.
It sounds innocent. To a lot of people, this looks exactly like what we call the post-operative ileus.
Which is what? Exactly.
So it just means the bowel is sleeping. It hasn't fully woken up from the trauma of the surgery yet, so things are a bit backed up.
And that's what everyone in the room wants to believe. The patient, the nurses, the doctors. But then, and this is the turning point, you look up at the monitor behind David's head.
And there is one number on that screen that does not fit the narrative at all.
His heart rate is 112 beats per minute.
And just like that, the room gets ice cold.
112. He's lying in bed. He's not running on a treadmill. He's not watching an action movie. He's just lying there scrolling on his phone.
That number, that 112, that is the siren. In that entire room, it is the only honest thing you're looking at.
Everything else is lying.
Everything else is lying to you. Drain is lying. The patient's face is lying. The low-grade fever is lying. But that heart rate is screaming that something is terribly wrong.
And this brings us to the critical question of our deep dive today. You are the clinician standing there. Do you just say, yeah, he's probably just anxious or maybe a little dehydrated and go grab a cup of coffee?
Or do you hit the panic button?
Because if this is what the research warns about, if this is an anastomotic leak, what actually happens if we miss it?
If you miss it right now, if you decide to walk away and say, let's check on him tomorrow morning, David is likely dead.
Wow. Dead, just from waiting overnight.
Dead, or if not dead, he is in profound septic shock. His organs are shutting down one by one, and he is facing a massive, mutilating surgery that will permanently change his life.
That fast.
12 to 24 hours. That is your entire window. When you see that heart rate, you are standing on the edge of a cliff, and the ground under your boots is crumbling.
So that is our mission today. We are going to completely break down this concept of the leak. We're going to understand the enemy.
We're going to learn how to be the detective that spots the single clue that everyone else on the ward misses.
And we are going to walk through the decision algorithm, the sort of how-to-play guide that surgeons use to save lives when the internal plumbing completely fails.
Let's do it. Let's get into section 1.
Section 1, the enemy. Now, we keep throwing around the word leak, and I think when a normal person hears leak, they imagine a dripping faucet under the kitchen sink.
Right, a slow drip.
It's annoying, it gets things wet, but it's not a house fire. But in the human body, a leak in the bowel is something entirely different, isn't it?
It is catastrophic. Let's define it properly so we're all on the same page. An anastomotic leak is a disruption of the integrity of the entero-enteric anastomosis.
Meaning the connection broke.
Exactly. We sewed 2 organic tubes together to make a watertight seal. That seal has breached. There is a hole.
And the result isn't just water dripping into a bucket?
No. The result is, well, a colorectal leak, one that happens way down in the large intestine, is essentially spilling stool.
Which is obviously full of bacteria.
Millions and millions of colonies.
Yeah.
It causes a massive, overwhelming bacterial infection. But a small bowel leak, which is what David has, that is an entirely different beast.
Why? Is it cleaner?
In terms of raw bacterial count, yes, slightly cleaner. But the biological payload is chemically different. The small intestine is the engine room of human digestion.
Meaning it's full of chemicals.
Active digestive enzymes. Things like amylase, trypsin, lipase, plus a huge dump of bile salts coming down from the liver.
So it's essentially a chemical cocktail.
It is absolute chemical warfare. These fluids exist to break down meat, to dissolve fat, to rip apart proteins. When that fluid spills out of the protective lining of the bowel and into the abdominal cavity, it doesn't just infect the surrounding tissue.
It digests it.
It literally digests it.
Oh, wow. So it's not just an infection. It's like an acid burn happening inside your stomach.
Exactly. It causes what we call a chemical peritonitis. It burns the delicate lining of the abdomen. And this causes an immediate, massive inflammatory response from the body.
Which explains why the symptoms hit so fast.
Right. This is why small bowel leaks tend to present much earlier and much more dramatically than colon leaks. The body reacts instantly to being burned from the inside.
Okay, so that perfectly explains this cascade of deterioration mentioned in our notes.
It's a domino effect. It starts with the leak, the fluid hits the sterile cavity, then you get that local contamination and the chemical burn. The body screams in absolute panic, releasing cytokines. These are stress hormones directly into the blood.
And that's RRS, right?
Yes, systemic inflammatory response syndrome. The whole body goes on high alert. Then the bacteria that are in that fluid join the party, and you cross the line into sepsis.
The blood gets infected.
Right. And as the sepsis ramps up, the blood vessels dilate, the blood pressure drops dangerously low, the major organs start to starve for oxygen, and boom, you are in septic shock.
And with small bowel fluid, because of those enzymes, this whole timeline is heavily compressed.
It's like putting a brick on the accelerator pedal. Speed is absolutely everything here.
I want to circle back to the timeline itself. We said David is on POD4, postoperative day 4. Why 4? Why not day 1 or day 10? Is there something biologically special about the 4th day?
There is some truly fascinating biology happening here. And it all comes down to collagen.
Collagen, like the stuff people put in skin creams.
The very same. It's the structural protein that literally holds our bodies together. When a surgeon sews 2 ends of the ball together for the first day or 2, it's just the physical stitches or the metal staples doing all the mechanical work.
Holding it shut by force.
Right. But biologically, the body realizes there's been trauma. So it starts a microscopic process called collagenylysis.
Collagenylysis. Breaking down collagen.
Precisely. It starts aggressively breaking down the old, damaged collagen right at the wound edge to clear out the cellular debris and make room for brand new, healthy tissue to grow.
So let me get this straight. The body dissolves its own internal glue before it even finishes making the new glue.
That is exactly what happens. Between day 3 and day 5 after surgery, the bowel wall is actually at its absolute weakest point. The old collagen is dissolving away, but the new, strong collagen matrix hasn't had time to fully bridge the gap yet.
We called this the lag phase, right?
The lag phase.
It's like a construction crew taking down the structural scaffolding before the cement has actually dried.
That is a perfect analogy. So purely from a physics and a biology standpoint, day 3 to day 5 is the extreme danger zone. If there's going to be a mechanical failure, maybe the blood supply to the area wasn't quite good enough, or maybe the surgeon left just a little too much tension on the stitches, the tissue is going to fall apart right in this window.
That is terrifying. It's like a structural failure is basically programmed into the natural healing process.
We call it the biological valley of death. And it is exactly why when you are walking the ward and you see a patient on day 4 who isn't steadily getting better, you have to be wildly paranoid.
Okay, let's move into section 2, the detective work. Because this is where the human element really comes in. We know the bridge is most likely to collapse on day 4. We know the enemy is this chemical fire. But how do we actually spot it? Because back in the intro, you agreed that David looked mostly okay.
And this brings us to the trap of normalcy. It is arguably the single most dangerous cognitive bias in all of surgery.
The trap of normalcy.
Think about human nature. You, the doctor, want the patient to be fine. The nurses want the patient to be fine. David desperately wants to be fine. So when you look at his ambiguous symptoms, a little bloating, maybe a little nausea, your brain automatically searches for the most benign explanation.
Which is post-op, Elias. His bowel is just sleepy.
Exactly. You rationalize it away.
But to be fair to the doctors, sleepy bowel, or ileus, really is incredibly common, right? I mean, almost everyone gets it to some degree after open abdominal surgery.
Oh, absolutely. It's totally expected. But here is the critical differentiator that you have to look for. With standard ileus, the patient is uncomfortable, they feel gross, but they are hemodynamically stable. They aren't getting progressively worse hour by hour. With a leak, there is a distinct downward trajectory.
But the symptoms are so muddy. A low fever, who cares he had surgery? A bit of abdominal pain, same thing. It's so easy to miss.
And that brings us right back to the golden rule from the source text. The one vital sign that cuts through all the psychological noise. Tachycardia.
The elevated heart rate?
The heart rate.
Uh-huh.
Our source material is incredibly adamant about this point. Unexplained tachycardia is the single most reliable early sign of an anastomotic leak, period.
I really want to push on this a bit. Why the heart? Why does the heart somehow know there's a disaster before the rest of the body shows it?
It's pure physiology. Think about that chemical burn starting deep in the belly. The body subconsciously detects a massive threat. The sympathetic nervous system, your basic fight or flight response, kicks into high gear instantly.
Before you even feel it consciously.
Right. And simultaneously, that massive local inflammation causes the blood vessels in the abdomen to dilate, to open up wide. This causes a subtle drop in systemic vascular resistance.
So the overall blood pressure starts to sag?
Just a tiny bit at first.
Yeah.
But the heart is a mechanical pump, and it compensates for that drop instantly. It starts pumping faster to keep the pressure stable and to rapidly circulate immune cells to the burn site. It is a hardwired reflex.
So this happens fast.
It happens hours, sometimes almost a full day, before the fever ever spikes.
Wait, why does the fever take so long?
Because generating a fever takes a massive amount of metabolic work. The body has to literally turn up its internal thermostat and shiver to generate heat. The white blood cell count. That takes time to mobilize fresh cells out of the bone marrow. Those are what we call lagging indicators.
But the heart rate is a leading indicator.
Exactly. You are looking at a real-time feed. If you were standing at the bedside waiting for the white blood cell count to go up on tomorrow's lab draw, you are looking at a snapshot of the past. You are already behind the 8 ball.
But here's the counter-argument, and I'm just playing devil's advocate here because I know listeners are thinking it. David is in pain. Pain makes your heart beat faster. David is probably incredibly anxious about being in the hospital. Anxiety makes your heart beat faster. How on earth do you know it's a chemical leak and not just a scared guy who needs a painkiller?
That is exactly why we always use the specific phrase, unexplained tachycardia, or tachycardia out of proportion.
Out of proportion to what?
To the clinical picture. If David tells you his pain is a manageable 3 out of 10, but his heart rate is sustained at 120, that does not match.
I see.
Or, let's say you test your theory. You give him some IV pain medication, you give him a liter of IV fluids in case he's just dry. He calms down, he says he feels better, he even falls asleep. But you look at the monitor, and his sleeping heart rate is still hovering at 115. That is unexplained.
The numbers absolutely have to match the narrative the patient is giving you.
Exactly. If the narrative is, I'm doing fine, but the heart muscle is saying, I am currently running a sprint, you must trust the heart. The heart is the ultimate truth teller.
Okay, so the heart rate is the siren. What are the other supporting clues? You mentioned the NG tube output increasing earlier.
Right. This is a subtle physical sign, but a really important one. If the bowel was starting to wake up and work properly, the fluid output from the stomach tube should be steadily going down each day.
Because the fluid is moving down the digestive tract normally.
Right. If suddenly on day 4 you are sucking a liter or more of fluid out of the stomach, it means the downstream bowel has hit a wall and stopped working again. It's been paralyzed by the sudden inflammation from the leak.
It's a physiological roadblock.
Correct. So a persistent ileus that stretches beyond day 3 is a huge red flag. Steadily increasing abdominal pain is a red flag. And if you do look at labs, the CRP C-reactive protein is key.
That's an inflammatory marker in the blood, right?
Yes. If you check a CRP and it's shooting up over 150 on day 3 or day 4, that is highly, highly specific for a major surgical complication.
Okay, but what about the drain? I feel like we really need to address the drain again because it's such a visual trap. David's drain was clear. It had minimal output. How can a patient have a massive, life-threatening internal leak and a totally clean drain sitting right there?
Because at the end of the day, drains are just dumb plastic tubes. They only sit exactly where the surgeon placed them 4 days ago.
But the leak could be somewhere else.
Think about the geometry of the abdomen. If the actual leak springs a hole just 3 inches to the left of the drain tip, the drain won't catch it.
Wow.
Or what often happens is a healthy loop of bowel just flops over and physically covers the holes in the drain tube. Or the omentum, which is this fatty apron inside the belly that naturally migrates to infection, it literally wraps around the drain and plugs it up entirely.
It essentially clogs its own warning system.
Yes. So the drain stays perfectly dry while a disaster unfolds 2 inches away.
So basically, a dirty drain full of bile proves you have a leak, but a perfectly clean drain proves absolutely nothing.
Precisely. We officially call it a sentinel drain, but honestly, it's a sentry that falls asleep at its post half the time.
Yeah.
You cannot ever rely on a clean drain to rule out a leak if the heart rate is telling you otherwise.
All right, so we have the clinical suspicion. We saw the tachycardia. We're properly paranoid now. Now we need to act. We need to investigate. This brings us to section 3, the investigation. Because we can't just guess, we need to see inside.
We need a map. We have to get imaging.
But do we just scan everyone who has a fast heart rate?
No. Here's the first major fork in the decision road. The choice to scan depends entirely on one single concept: hemodynamic stability.
Meaning their blood pressure is holding up.
Right, because you have to think about the logistics of the hospital. Where is the CT scanner usually located?
In my experience, it's always in the basement.
It's in the basement, it's down a long hallway, it's down a slow elevator, is physically far away from the ICU nurses, far away from the crash cart, and far away from the surgeons. We actually have a nickname for that journey. We call it the Tunnel of Death.
The Tunnel of Death.
Yeah.
That is a grim nickname for a hospital corridor.
It's earned. It really is. Because if you take an unstable patient, someone whose blood pressure is already crashing, whose organs are failing, and you put them alone into that plastic donut,
They could arrest in the machine.
they might code right there. And you cannot do effective CPR while someone is stuck inside a CT scanner tube. They will die while you are trying to take a picture of what's killing them. You never, ever send an unstable patient to the tunnel of death.
So let's say David wasn't just sitting there scrolling. Let's say he was hypotensive. His blood pressure is 70/40. He's barely conscious, pale, sweating. What do we do then?
You skip the scanner entirely, you bypass radiology, you wheel that bed straight through the double doors of the operating theater. Your eyes and your gloved hands are going to be the scan. You just open them up and find the problem manually.
Wow. But okay, back to our actual scenario. David is clinically stable. His heart rate is 112, but his blood pressure is totally normal. He's awake, he's chatting with you.
In that case, we have the luxury of time to get the map. We scan him, and we need to be extremely specific about the exact order we put into the computer. You want a CT of the abdomen and pelvis with 4T contrast.
4V contrast. Why is the contrast dye non-negotiable? Can't you just do a regular scan?
A regular scan without dye just shows you gray blobs of tissue. It's nearly useless for this. The IV contrast lights up the blood vessels. It highlights areas of angry inflammation. But most importantly, we are specifically hunting for a phenomenon called extravasation.
Extravasation.
Yeah.
Fancy radiologist word. What does it actually mean in plain English?
It literally means leakage. You inject the bright dye into the patient. It circulates, and on the screen, you suddenly see a bright white bloom of that dye actively pooling in the abdominal cavity where it absolutely should not be. It's escaping the pipe.
That is the smoking gun.
It is the smoking gun caught on camera.
But what if you don't see the dye actively pouring out? Maybe the leak is slow or intermittent.
Then you look for the secondary, more subtle signs. You look for localized collections. Imagine looking at the scan and seeing a dark, encapsulated pocket of fluid resting right next to the surgical joint. That's an abscess trying to form. Or you look very closely for free air.
Free air. I've heard this term on medical dramas. Free air inside the abdomen is always a surgical emergency, right?
Usually, yes.
Yeah.
But here's the tricky part of this specific scenario. Remember, David just had his belly sliced open 4 days ago. When surgeons open you up, room air naturally gets inside. So seeing a little bit of trapped air on a scan is actually totally normal for a week or two.
So how do you tell normal surgical air from danger air?
Volume and location. If you see diffuse free air, meaning large pockets of gas spreading everywhere throughout the abdomen, far away from the incision, that implies there is a continuous active source pushing new gas into the cavity.
Meaning the bowel is basically exhaling gas into the belly.
Exactly. So diffuse free air on POD4 is a massive screening red flag.
Okay, so the scan is done. The patient is back in bed. The radiologist calls you with the results. Now comes the really hard part. This is section 4, the decision algorithm. This is the how to play section of the deep dive.
This is where the true art of surgery meets the hard science. You have made the diagnosis. You know there is a leak. Now what do you actually do about it? And once again, the decision tree splits cleanly into 2 distinct pathways based on the patient's condition. Let's call them the red scenario and the yellow scenario.
Let's start with the absolute nightmare, the red scenario.
The red scenario is the unstable patient, or it's the patient who has developed diffuse peritonitis.
Diffuse peritonitis. Paint a picture of what that physically looks like at the bedside.
It means the chemical burn is no longer contained to one small spot. It has splashed and spread across the entire abdominal cavity. If you touch the patient's belly, it is rigid. It feels literally like a wooden board because the abdominal muscles are involuntarily spasming to protect the inflamed organs beneath.
And patients.
They are in absolute agony. They can't even bump the bed without screaming. Their lactate levels in their blood are rising rapidly, which tells us their cells are suffocating on a microscopic level. They are tipping right over the edge into full-blown septic shock.
This is a crash situation.
This is a drop everything and run crash. The action plan here is incredibly aggressive. Step 1, resuscitate. You are pumping liters of IV fluids into them, maybe starting pressor medications to artificially squeeze their blood vessels and keep their blood pressure from bottoming out. Step 2, you bombard their system with the strongest broad-spectrum antibiotics you have. You have to start killing the bacteria that have entered the bloodstream immediately. And step 3,
Immediate laparotomy.
knife to skin as fast as possible. You open the belly wide.
Now, this brings up a point that completely surprised me when I was reading the source research for this episode. This deep dive. You open the belly, you look down, and you find the physical hole in the bowel. My instinct, and I assume almost everyone's instinct who isn't a surgeon, is to say, great, we found it, sew it up, fix the hole.
And that instinct is exactly how you kill the patient.
Wait, why? Explain that.
This is the golden surgical rule for the red scenario. Do not attempt primary reanastomosis in a septic abdomen, ever.
But if you don't sew it shut, the hole is still there. It's still leaking.
You have to understand the physical condition of the tissue during severe sepsis. The bowel wall isn't normal anymore. It becomes severely edematous. It swells up with inflammatory fluid until it's twice its normal thickness, and it becomes something we call friable.
Friable, what does that feel like?
It feels like wet, cheap tissue paper or crumbly feta cheese. If you take a sharp surgical needle and heavy thread and you try to pass it through that swollen, diseased tissue and pull a knot tight, the thread will literally just rip right through the bowel wall like a wire through butter.
Oh, wow. So it won't even hold the stitch?
Will hold. You will just end up tearing a much bigger hole. And even if, by some miracle, you get the knot to hold for 5 minutes, the biological healing capacity of that septic tissue is absolutely zero. It will rot and break down again within 24 hours.
So you literally cannot fix the pipe.
You cannot fix the pipe. The situation is fundamentally changed. So you must change your goal as a surgeon. The goal is no longer reconstruction. The goal is purely damage control.
So if you can't sew the hole shut, what do you actually do?
You cut out the broken section, you take the two open leaking ends of the bowel, and you physically bring them out through a hole in the abdominal wall. You create a stoma, specifically what we often call a double-barrel stoma.
You give the patient a bag.
You give them an ostomy bag, you take the problem, and you exteriorize it. Now, whatever digestive fluid or stool comes down the pipe empties directly into the plastic bag on their stomach, completely bypassing the delicate infected cavity inside. You wash out the remaining infection with liters of saline, and you get out of the operating room.
Man, that is a heavy outcome. Going to sleep hoping for a fix and waking up with a stoma on your abdomen is profoundly traumatic for a patient.
It is a huge psychological blow. It alters their body image, their daily life, how they dress, how they sleep. But the surgical mantra here is life over continuity.
You can't reconstruct a dead patient.
Exactly. You do whatever it takes to survive the sepsis today. You let the infection clear, you let the patient heal, and then maybe 3 to 6 months down the line, when they have their strength back and we look inside and see the tissues are pink and supple and healthy again, then we go back in, take down the stoma, and put the plumbing back together.
It's playing a very long game.
It is the only guaranteed way to win the game in the red scenario.
Okay, that makes sense. Now let's dial the intensity back just a bit. Let's look at the yellow scenario, because this brings us back to our guy, David.
Right. So remember, David had the alarming tachycardia, but he was hemodynamically stable. Blood pressure was fine. We got the scan. And the radiologist says the scan shows a leak. Yes, but crucially, it is a contained leak.
Contained. Explain how a leak contains itself.
The human body is capable of miraculous things. When that fluid first started weeping out of the hole, the body sensed it. The omentum, that fat apron we talked about, physically migrated over to wrap around the area. The other healthy loops of bowel squished in tight around it. They literally built a barricade made of tissue to wall off the toxic leak.
So there is a puddle of pus and digestive fluid, but it's trapped in a tiny pocket.
Exactly. The chemical fire is safely contained inside a fireplace rather than burning down the entire living room.
And because it's contained, that changes your options.
Completely. Because the patient isn't in septic shock, we don't necessarily have to slice his abdomen wide open again.
So what's the play here?
The play is achieving source control, but doing it via interventional radiology. We take David down to the CT scanner. But this time, the radiologist uses the live scan images to guide a very long, thin needle straight through the skin of his side, navigating safely between the organs and plunging right into the center of that hidden pocket of fluid.
And they place a drain directly into the abscess?
They slide a drain over the needle, hook it up to suction, and they just suck the poison out of the body.
So no big surgery, no general anesthesia.
No scalpel. Just a needle and a plastic tube. We drain the toxic collection dry. We start them on heavy-duty IV antibiotics, something powerful like piperacillin tazobactam to scrub the bloodstream clean.
Right.
And then we just sit back and watch.
Active, intense observation.
We call it controlled play. We watch the new drain output carefully. We watch his heart rate monitor like hawks. If that drain successfully sucks all the fluid out, the walls of that little cavity will naturally collapse inward. And often, and this is the amazing part, that tiny hole in the bowel will actually heal and seal itself shut entirely on its own simply because we remove the surrounding pressure and infection.
That feels like absolute magic compared to the nightmare of the stoma.
It is a massive triumph of modern medicine when it works. But there's a very big catch to the yellow scenario.
There is always a catch in medicine.
You have to monitor him obsessively, because at any given second, that delicately contained leak could violently burst. That biological barricade of omentum could give way. And if he deteriorates, if that heart rate spikes from 110 to 140, if his blood pressure suddenly tanks, if his belly goes rigid,
You pivot?
you immediately abandon the yellow plan. You switch to the red plan and you sprint to the operating room.
So it's an incredibly dynamic, fluid situation. You can't just place the needle drain, high-five the team, and assume you won.
Never. You are watching him every single hour, ready to move.
Let's bring this all the way to Section 5. Resolving the case study. Let's finally finish David's story so our listeners aren't left hanging.
So to recap, we left him sitting in bed with a heart rate of 112 on day 4. The surgical team recognized the sign. They didn't fall into the trap of normalcy. They ordered the contrast CT scan.
And the scan showed exactly what we just discussed. A localized, walled-off collection sitting right near the ileal anastomosis.
A textbook yellow scenario.
So they didn't rush him to the OR with a scalpel?
No. They made the calm, calculated call. They got interventional radiology involved. They placed the percutaneous drain directly into the pocket. They started the piperacillin tazobactam.
And what actually happened next?
Within about 12 hours of the drain going in, the numbers started to shift. The heart rate began to slowly drift down. 112, then 100, then down to 90. The low-grade fever broke. His abdominal pain settled down completely. That new drain pulled out about 100 milliliters of really cloudy, nasty fluid on the first day, and then the fluid slowly started to turn clear.
And the final outcome for David?
David walked out of the hospital and went home 7 days later. He had to keep the drain taped to his side for a couple of weeks, but eventually it stopped draining entirely, and they just pulled the tube out in a regular clinic visit. No soma, no horrific second surgery. He is fully healed and back at work.
Man, that is a massive, massive win for the medical team.
It is the absolute perfect outcome.
Mm.
But I want to play a game here. I want to play the alternate reality game, the sliding doors moment.
Let's do it. What is the alternate timeline?
Let's rewind to 2 p.m. on day 4. What if the junior doctor looking at the monitor decided to ignore that heart rate of 112?
Scenario B. The doctor says, hey, he's awake, he's scrolling on his phone, he looks totally fine, he's probably just a little dry. Let's just give him a bag of IV fluids and reevaluate tomorrow.
Exactly. They wait. They go home for the night. While the hospital sleeps, that contained collection in David's belly keeps slowly filling up with more and more highly caustic digestive enzymes. The pressure inside that tiny pocket builds and builds until eventually the wall of momentum just gives way.
A dam physically breaks.
The dam completely breaks. Now, all that highly toxic acidic fluid floods freely into the entire abdominal cavity. Fast forward to 4 a.m. David wakes up screaming in excruciating pain. He is wriggling, violently shaking uncontrollably. The nurses rush in, they check his vitals, and his blood pressures crash to 80/40.
Now he is highly unstable.
Now he has crossed into the red scenario. He gets urgently rushed to the OR. He is profoundly septic. The surgeon opens him up, and his tissues are literally falling apart in their hands. The surgeon has zero choice. They spend 3 hours washing out his abdomen, and they are forced to give him a permanent or semi-permanent stoma.
And his recovery?
Brutal. He spends the next 2 weeks in the intensive care unit, hooked up to a ventilator, fighting for his life against sepsis. His kidneys take a massive hit from the low blood pressure. He eventually survives, but he goes home a month later with an ostomy bag, a huge risk for future hernias, and facing months of grueling rehabilitation.
And the absolute only difference between David A., who went back to work in a week, and David B., who almost died in the ICU with a stoma, was
a doctor noticing a heart rate of 112, recognizing it was unexplained, and choosing to act on it immediately. That's it. That one observation is the entire margin between a minor bump in the road and a life-altering catastrophe.
It really drives home the idea that playing the game of surgery well isn't just about having the best, steadiest hands in the operating room. It's about having the sharpest eyes on the recovery ward.
We have a saying, surgery is 25% cutting and 75% decision-making.
That is profound. Let's transition to Section 6, surgical strategy and prevention. Because we have spent this whole time talking about how to fix the mess once it happens. But how do we prevent the mess in the first place? How do surgeons even sleep at night knowing that collagenalysis is going to try to dissolve their work on day 4?
Honestly, we obsess over technique. We fixate on the tiny details to try and get the statistical leak rate down below 3%, or ideally even below 1%. There are core pillars to creating a safe anastomosis.
What is the single most important pillar?
Blood supply. It always comes back to blood. If the 2 ends of the bowel you are holding look pale or dusky or even slightly blue, they are already dead. You absolutely cannot sew dead tissue to dead tissue and expect it to heal. You have to use your scalpel to cut further and further back along the intestine until you see bright cherry red tissue that bleeds briskly when you touch it.
You have to connect living tissue to living tissue.
Exactly. If there is no blood flow, there is no oxygen. If there is no oxygen, there is no collagen matrix formation.
What's the second pillar?
Tension. You cannot physically pull the 2 ends of the bowel together tight to make them reach. If the connection looks like a tight vibrated guitar string, it is guaranteed to snap or pull the stitches right through the tissue as soon as the patient moves. The bowel needs to lie together comfortably, loosely.
How do you achieve that if you just cut a huge section out?
That requires something we call mobilization. You have to surgically free up the surrounding attachments of the bowel deeper in the abdomen so that it can stretch and reach the other side easily without pulling.
Okay, blood supply and tension. What else is on the checklist?
Distal obstruction. This is a very basic plumbing rule. You cannot fix a leaky pipe if there is a massive clog further down the line. If there is a tumor or severe scar tissue or a stricture further down the digestive tract, the pressure from digestion will just build up and eventually blow out your brand new, delicate connection. You have to ensure the road ahead is completely clear.
Make sure the fluid actually has somewhere to go.
Right. And finally, there's gentle tissue handling.
Which sounds obvious, but I imagine it's hard in practice.
This is truly what separates the master, veteran surgeons from the heavy-handed butchers. If you grab the edge of the bowel with harsh, crushing metal forceps, you are instantly traumatizing that tissue. You are creating microscopic necrosis, dead spots, right exactly where you desperately need perfect cellular healing. You have to treat the bowel edge like it's made of wet tissue paper.
It really is an art form, isn't it?
It really is. It's about having profound respect for the tissue you are manipulating.
Before we move to the close, I want to talk about that really advanced insight from the source notes. The paradox of the small bowel.
Oh, right. This is a bit of a mind bender when you first learn it. Statistically speaking, small bowel leaks actually have a lower overall mortality rate than colorectal leaks, provided they are detected early.
Wait, lower mortality. But you just spent the first half of the deep dive telling us that small bowel fluid is literally acidic chemical warfare that digests the organs. How can that possibly be less deadly than a colon leak?
Because of the vascularity. The small bowel has an incredibly robust, massive blood supply.
Yeah.
Because of that, it desperately wants to heal. If you can just intervene quickly, if you divert the chemical stream or put a drain in to remove the infection, the highly vascular small bowel will aggressively regenerate and often seal itself up very quickly. The colon, on the other hand, is much lazier. It has a comparatively poor blood supply, so once it breaks open, it heals very, very slowly, and the heavy bacterial load overwhelms the system.
Ah, okay. But there's a flip side to this paradox.
The flip side is exactly what makes the small bowel so terrifying in the short term: the liquid nature of the leak. Because small bowel effluent is highly liquid, it spreads throughout the abdomen much faster than solid stool from a colon leak. It causes that diffuse peritonitis at lightning speed.
So to summarize, small bowel leaks will kill you much faster if you ignore them, but they are actually easier for the body to fix if you catch them immediately.
High risk, high reward. It demands vigilance.
And speaking of risk, we mentioned the stoma as a major complication. Are there any other massive complications if things go wrong?
In the absolute worst-case scenarios, the neglected leaks where the patient sits in the ward for days, you can develop something called abdominal compartment syndrome.
That sounds intense. What is that?
The belly gets so incredibly swollen with inflammatory fluid pus and expanding bowel gas that the physical pressure inside the abdomen rises to critical levels. The pressure gets so high that it literally crushes the vena cava, which is the massive vein returning blood to the heart. It physically crushes the kidneys so they stop making urine. And it pushes up so hard on the diaphragm that the lungs cannot expand to take a breath.
The body literally just runs out of physical room.
It does. And in those dire cases, when we do surgery, we can't even sew the skin of the abdomen closed at the end. If we closed it, the pressure would kill them. So we have to intentionally leave their abdomen wide open.
Just open to the air.
We cover the exposed organs with a sterile plastic sheet called a Bogota bag, or we use a specialized negative pressure vacuum dressing. We leave them zipped open in the ICU for days until the massive swelling finally goes down. That is the true definition of damage control surgery.
It is genuinely staggering how quickly a routine recovery can spiral into an open abdomen in the ICU if the team isn't paying strict attention.
It is a deeply humbling profession. You can never let your guard down.
Let's bring it all home. We have covered the anatomy, the violent physiology of the leak, the subtle diagnosis, the imaging strategies, and the surgical algorithms. Let's do the outro. Let's summarize the ultimate surgical game plan for our listeners so they can walk away with the core truths.
Let's boil it all down. Whether you are a medical student, an ICU nurse, a junior resident, or just someone fascinated by how doctors have to think under pressure, here are the 6 rules of the road for managing anastomotic leaks.
Rule number 1.
Suspect early. Do not ever allow yourself to be lulled to sleep by the trap of normalcy. Remember that postoperative day 4 is the biological danger zone for collagen breakdown. Be professionally paranoid.
Rule number 2.
Respect the tachycardia. It is the absolute truth teller. If the patient's resting heart rate is elevated and you cannot easily and quickly explain exactly why, you must assume it is a leak until proven otherwise. Do not wait hours for a fever to appear. Do not wait until tomorrow for the white blood cell count lab results. Trust what the heart is screaming at you.
Rule number 3.
Scan is stable. If the patient's blood pressure is holding strong, go get the map. Order the CT scan and make sure it includes IV contrast. You are specifically hunting for extravasation of dye or diffuse free air.
Rule number 4.
Operate if unstable. Do not ever send a crashing hypotensive patient down the hallway to the tunnel of death. Skip the scanner and go straight to the operating theater.
Rule number 5. And I feel like this is the one you need to tattoo on your brain if you're a surgeon.
Absolutely. No heroic reanastomosis in a septic abdomen. If you open them up and the bowel tissue is friable, swollen, and inflamed, do not try to sew it back together. Your stitches will fail and you will kill a patient.
And finally, rule number 6.
Source control is always greater than reconstruction. Your singular job in a crisis is to save the patient's life, not to preserve their bowel continuity. Stomas can always be reversed later. Death cannot be reversed.
That is an incredibly powerful, clear framework.
It's more than a framework. It is a literal survival guide.
You know, I want to leave the listener with one final thought to mull over. We talked a whole lot about time today.
We did. Time is the ultimate currency here.
Right. And the overarching takeaway seems to be this. In surgery, delay mathematically equals mortality. The tiny difference between placing a controlled needle drain and slicing open a highly septic abdomen. The difference between David going home to his family in a week versus struggling on a ventilator in the ICU with a stoma is often just a handful of hours of human indecision.
It comes down to one person noticing a trend and acting on it.
Exactly. It makes you wonder, what if the biggest actual risk in modern surgery isn't the physical sharpness of the scalpel or even the technical skill of the surgeon's hands? What if the greatest danger is simply the clock ticking while a human mind tries to convince itself that everything is fine?
That is the psychological burden of observation. When the numbers on the screen, like that lone heart rate of 112, refuse to match the comforting story that the patient looks fine, you have to possess the courage to believe the cold data. The body does not lie to us. We just have to be willing to listen to the uncomfortable truth.
The body does not lie. That is the perfect place to end this. Thank you for taking this incredibly intense deep dive with us today. I honestly feel like I am never going to look at a hospital heart rate monitor the exact same way ever again.
It truly is the most important screen in the entire room.
Thanks for listening, everyone. Keep asking the hard questions, keep pushing to learn how things really work, and we will catch you on the next deep dive.
Stay curious.